At the outset, I'm very happy to share my talk that is titled Management of Early and Late Complication of Fracture Supracondylar Humerus. The complication of fracture supracondylar humerus can be classified as early and the late complication. The early complications are vascular insufficiency in the form of pink pulseless hand. This topic will be covered by some other speaker. The other vascular insufficiency complication is forearm compartment syndrome, neurological injuries, floating injuries, and myositis ossificans. The late complication can be malunion. Malunion can be cubitus varus, most common, cubitus valgus, and extension malunion. Stiffness, elbow, Waxman ischemic contracture, tardial palsy, iatrogenic, which are related to the procedure or the surgery. The forearm compartment syndrome is around 0.1% to 0.3% of the displaced fracture supracondylar of humerus. The risk factors are gross swelling, elbow fixed to more with the fraction more than 90 degree, tight strapping of the cast, associated fracture forearms, and the high velocity trauma, which increases the compartment pressure. The suggestive sign and symptoms are agitation, anxiety, increased requirement of the analgesics, swelling with the tight forearm, ecchymosis, and pucker sign, and the involvement of median nerve. Involvement of neurological deficit is usually associated with vascular insufficiency in many cases. The diagnosis of the compartment syndrome is usually clinical. The pressure management is only done in the patient with altered sensorium. Most commonly, compartment syndrome develop in the volar compartment. In severe cases and in few conditions, it may develop in the dorsal compartment. To minimize the risk of compartment syndrome, we have to immobilize the elbow at 30-degree flexion or at 60 to 70 degree after surgery. If the limb, this vascularization is existing more than 6 hours or the conservative method failed, then the emergency fasciotomy has to be done. The fasciotomy is not recommended after 36 hours because of irreversible damage to the muscles and the nerves and because of reperfusion syndrome. If no timely intervention is done, then chances of Waxman ischemic contracture development are there. The nerve injuries are around 6.5 to 19% of the displaced fracture supracondylar. These injuries can be primary lesion occurring before reduction or surgery, maybe due to fracture displacement, and secondary lesion after reduction or the surgery maybe due to stretching, entrapment of the nerve in the fracture site, or nerve disruption. The extension type of fracture with the posterior medial displacement is usually associated with radial nerve involvement, and posterior lateral displacement is associated with neurovascular with the median nerve or anterior nerve involvement. The flexion type is usually associated with ulnar nerve injury with vascular involvement. The ulnar nerve involvement in extension type of fracture may occur if we are fixing by the medial pin insertion. The majority of the nerve injuries are neuropraxia, which heals spontaneously, except compound injuries, or in select cases. The Magnet et al. In 2009 observed that the early exploration is done in all the cases, but in 2014, in a multi-centric retrospective study of 4,400 patients, the Barrett et al. Concluded that the isolated anterior inferior nerve should not be explored and surgery is not indicated. The Valencia et al. Observed in 2015 that within 3 months, 100% radial nerve recovery occurs. 87.5% median nerve recovery occur in 2.5 months. And the worst is the ulnar nerve, which improves only 25%. That too takes around 5 months. If sensory motor symptom and sign appear after close manipulation, then we have to remove the POP, remaneuver the fracture, and if improves, wait and watch, otherwise go for open reduction and exploration. If sensory motor symptom and sign after K-wire fixation, then we have to withdraw the K-wire, reposition the K-wire with or without exploration of the nerve. If sensory motor symptom or sign after open reduction, then re-expose the fracture and exploration of the nerve. The management of floating elbow, because floating elbow is only 5% associated with fracture supracondylar of humerus. It occurs when the supracondylar humerus is associated with ipsilateral fracture, both bone forearm proximal 1/3. The incidence of compound injury and neurovascular complication in floating elbow are very high, and its management is the close or the open reduction of supracondylar humerus with K-wire fixation with conservative or internal fixation of both bone forearm. The management of myositis ossificans it's a rare complication. The history of trauma, swelling, massage, pain, and inability to use suggests the myositis. If it is acute, then it may present with a swelling, hot, redness, tenderness, painful restriction of movement. When it's old or healed, then no sign of active inflammation with painless restriction of elbow movements. Usually clinical diagnosis, but before surgery, we have to go for local part radiograph. The acute is managed by no massaging, anti-inflammatory drugs, is preferably indomethacin, and rest to the part followed by gentle active movement. Old healed myositis is done by the excision of the bony mass. The management of cubitus varus which is the most common malunion, is around 48% in the literature, which has reduced now by 3% with better imaging and better method of fixation. If child is less than 4 years, some remodeling correction may occur. Posterior medial displacement causes higher Bowman angle, which may result into varus malunion. It is important to correct the cubitus varus because it is not only causing the cosmetic problem, but it also produces tardy ulnar palsy, rotatory instability, tricep snapping, and higher chances of condylar fractures. It can be corrected by corrective osteotomy or distraction osteogenesis. The most common osteotomy is the lateral close wedge osteotomy, modified French osteotomy. It should be done after the complete remodeling and consolidation. The lateral approach is most common surgical approach used to correct the varus. The posterior approach for the complex osteotomy gives bigger scar and more stiffness. We have, it's a triplanar deformity. If we want to correct all the three planes, then we have to go for dome osteotomy, but it is a controversial whether we need to correct the rotation. So varus with or without extension correction can be done by lateral close wedge osteotomy. The plate and screw is the most preferred method of fixation as per literature. The complication of varus correction are incomplete correction, lateral prominence, a loss of correction, nerve palsies, infection, and reoperation. Overall incidence of these complications is around 14%. The Walkman ischemic contracture can be mild. If it is early, then it is managed by conservative method with night extension splints. If it is late, then excision of the infarcted muscles or the lengthening of the tendon. Moderate to severe are managed by release of nerve compression. All three nerves should be released. The treatment of contracture by the excision or the lengthening. And in select cases, tendon transfer as recommended. The salvage bony procedures are there in the form of shortening of both bone forearm bones, carpectomy, and the joint fusion. The tardy ulnar palsy, it's not a very common complication. It may be due to the entrapment or the friction of the nerve around the callus, and neurolysis with or without anterior transposition is the treatment of choice. Thank you very much.